hear from him about his research in concussion today.
Yeah, unfortunately I'm on call for trauma too. So. Okay, checking a few things. Okay, so it was great to be here. Thank you, Michael. Let's do a survey. Okay, so I see lots of different kinds of faces. Who's Stanford student? Student. Okay, a lot of Stanford students. And who's not a Stanford? Okay, I know you. Okay, all right. So some people maybe had head injuries and stuff. How many of you are pre-med? Okay, all right. And how many are part of Michael's group? Who are part of the support group? Okay, go around and thank you very much for all your hard work. We appreciate it. So Michael, I'm a professor of neurosurgery here at Stanford. I came out here from Cornell. I was in New York before that 3 years ago. I came out here 3 years ago, and to start the concussion center, and also head up with Odette Harris the severe TBI program at Stanford. So I was asked to talk about my background and how I got interested in trauma and what I think is going to make a difference in that and so on. So. And I was talking to Bob Page over here about a little bit about some of the things we don't discuss in science, which is when you get a traumatic brain injury, it's a very sudden event, or a concussion, sudden event. And you're not the same person you were before. And I'm not talking about, because that's sort of, it's hard to investigate that. But it's a really big issue, is that you're one person, then suddenly there's an event, and you're a different person the next day. And but the thing is, your hippocampus doesn't change. I don't know why. They should probably change that program. But so the hippocampus has the remembered self. Okay, so what happens is now you're a different person, and you're comparing yourself to where you were before the injury. So there's people, even with mild as we don't say mild, but concussions, where people have trouble concentrating, they have trouble sleeping, they feel irritable, they don't feel like themselves. I have a scale of 1 to 10. I ask my patients who have a concussion, I said, 1 being yourself, 10 being an alien, how do you feel? And if it's immediately afterwards, you feel like a 10, I feel like an alien, I feel like an out-of-body experience, not me. And then gradually, as they recover, they come back to themselves. They say, I'm 5 now, I'm 4, 3, and I'm 1, I'm back to myself. But while they're out there being an 8 or 9, kind of an alien, they're comparing themselves to what they were before, and they can't do the things they were doing before. They used to listen to music and talk and do their studies, which a lot of you people do, and simultaneously now they can barely do one thing. So it's depressing, produces anxiety. So it's the remembered self. And then you have severe TBI patients who often end up with a disability. They're definitely not themselves, and they compare themselves. And so what do you do about that? So these are big issues, which I'm not going to get into. And hopefully some of the people around here who've experienced it can tell us how they cope with it and how they do it. Now, we all do it through aging, but it happens very slowly. I'm not the same guy I was when I was your age back in college, But it's real gradual, and you don't notice. And so it happens over time. And it's sort of something natural, whatever. And you do gain a few things along the way, hopefully. So I'm going to talk a little bit about how I got a traumatic brain injury and neurosurgery. And maybe I'm going to leave, well, not maybe, I'll leave time for questions at the end. And I just want to focus a little bit about, so I've got a kind of strange journey. I wasn't exactly following the route most people take when they go through medical studies. So I was very interested in neuroscience when I was an undergraduate, and I was trying to combine that with my clinical interest. And Cornell at that time had a program, MD PhD program in neuroscience, and I got accepted there, and so it was a really fun program because you got to do medical school. There's no medical students here, right? No, okay. It was a really fun program because, and most big academic medical centers have an MD and PhD program, where you get into about 10% of the medical students do MD PhD. And so the fun thing is you do 2 years of medical school, and then you do your research, get your PhD, and then you come back and finish medical school, and then you go on to do your stuff. And the main thing about the PhD part is you learn how to do science. You learn how to do good scientific thinking and all that. So I went through that. My interest was consciousness, so I did my PhD in the neurochemistry of coma, and looked at specifically hypoglycemic coma, and looking at different stages of wakefulness and what happens in the brain during those stages. And then when I came out of it, I stayed on at Cornell and did neurosurgery. And the first thing I saw, which I'll get into a little bit here, I guess the coma side, is I saw the first thing a neurosurgeon has to learn is how to make a hole in the skull and put a tube in, hit the middle of the brain where the spinal fluid is, to either monitor brain pressure, drain spinal fluid for brain swelling. It's also used for shunts for kids that have water in the brain. And it was just done by sort of dead reckoning, sort of like look at the scan, hit it. And so when I was a first year resident, I was making Swiss cheese out of the frontal lobe, like most first year residents. And then the professor came in, the attending, and just went like that and hit it. And I said, well, how do you do that? How do you aim and hit the middle of the brain where the spinal fluid is? And he goes, that's why the residency is 6 years. Well, now it's 7 years. But, it's like so it's sort of like, and so I really became. I just came off my PhD, so I thought you got to be something measurable. Something's going to be going on here. So that's a little thing coming up. So I'm going to start from coma, then end up in concussion, and really talk about the power of evidence improving patients' outcomes. Okay, next. So conflicts, because you're at Stanford, if you don't have a conflict, then you're not at Stanford. So I do, these are my contracts I have with the Department of Defense. So I have using eye tracking to screen for concussion. I'll talk about that. And then BTEC is the Brain Trauma Evidence-Based Consortium. We do the guidelines, the national guidelines for traumatic brain injury. And I'm on the board of SyncThink, which is a company that makes eye tracking goggles and VR. And so I'll talk about that in a little bit. Next. So, severity, we're talking about traumatic brain injury. Here it is. Mild, moderate, severe. And it's all consciousness, right? Mild is, we called it mild because it wasn't moderate or severe, but it's not mild. This is concussion, you're awake, your eyes are open, okay? You don't have a concussion if you're in coma. And then there's this Glasgow Coma Scale, which just describes eye opening and motor function and verbal. Basically, if your eyes are open, you're awake, it's called mild. If you're sleepy, got to pinch you to open your eyes, it's moderate. And if you pinch the person and they don't open their eyes, that's coma. Coma is you don't open your eyes, you don't follow commands, you're in coma. Okay, now sometimes people don't do that because they just don't feel like it. You can do an EEG and see if they're awake. But in general, that's how you follow. This is the way we put people in the ER. So right now I had a text from the neurosurgery resident, I got a patient in the ER, and they show me the scan, it's got a blood clot and all that, and da-da-da. But what I look for is this. The person's awake, okay? It's a much better prognosis than they're in coma. Okay, next. So, why are evidence-based guidelines important? So clinical practice is often inconsistent with evidence. A lot of times, people just do things because that's the way they were trained, and they don't look at the evidence supporting that. So you want to have evidence to reduce ineffective or harmful therapies. So we used to give steroids to everybody in coma and hyperventilate them. Actually, you remember the ambulance people back in the 80s had very large right biceps. Their left biceps weren't that big. Does anyone know why that would occur? It's one of those brain twisters. So EMT, the guy in the ambulance who's riding with the patient, has got a large right bicep. Left one, not that big.
Were they like holding patients?
Holding patients. Something to do with your arm, right? Mm-hmm. The hand. are they doing in the ambulance?
They're pinching them. Oh.
An bamboo bag over the person's mouth and they're ventilating them, right? So they're hyperventilating these patients. Why? Why are they hyperventilating? Well, because they're hyperventilating. They're nervous. The person's in coma, and they're rushing to the trauma center, and they're hyperventilating. They're hyperventilating because they remember reading somewhere that if you hyperventilate somebody, the brain shrinks. Does anyone know why that occurs? Why does the brain shrink when you hyperventilate? One of the reasons why you faint. Did you raise your hand? What happens when you hyperventilate? What happens to your carbon dioxide level?
Goes down.
Goes down, right? And so the blood vessels are very sensitive to carbon dioxide because theoretically they respond to metabolism, right? So you metabolize, and what comes off metabolism? Carbon dioxide. So if you have a lot of carbon dioxide, the vessels dilate to give you more oxygen and blood. It's a natural response. But if you hyperventilate and you artificially lower the carbon dioxide, the vessels shrink. Okay, so if there's less blood in the brain per unit time, what happens? The volume comes down, the brain shrinks, right? So no brain swelling because you're hyperventilating. The bad news is there's no blood flow either. And that's why people who get anxious, hyperventilate, faint, because you constrict the blood vessels in the brain. No blood flow goes there. You drop. You forget about what you were anxious about. Start breathing normally again. CO2 rises, and you wake up. So there's a little process for you. So the problem was in the ambulance, these guys were all hyperventilating. What's the evidence that hyperventilation improves outcome in the ambulance? The answer was no, it doesn't. Actually, the reverse. The hyperventilation delays recovery, can produce strokes, and all sorts of things. And then there's a thing about giving steroids. So we'll give steroids because that shrinks brain tumors. So it must shrink, swelling from trauma. And in fact, and a lot of people say it doesn't hurt anybody. And so there were some very good trials, and then there was a 10,000 person trial called CRASH, and they found that the mortality was higher with people getting steroids. So they found the evidence, and guess what? Now we don't give steroids, we don't hyperventilate, give lots of fluids to patients in the ambulance, and they come to the ER, and guess what? The outcome's much better. So this just shows compliance with evidence, and it was very low to begin with, and now it's creeping up. This is steroids right now is almost 100% of people don't use steroids. And then ICP monitoring come up even further, it's closer to 90%. So it improves patient outcomes. Okay, and I started the Brain Trauma Foundation when I was a resident. I was a chief resident at Cornell because I was going around. Well, I'll get into it. But when I was a first year resident, I invented that device, which I'll show you, to hit the middle of the brain. And from that, I started the company, and then I got the foundation to develop the guidelines. And now this is 30 years old now, Brain Trauma Foundation. And we do the national guidelines for traumatic brain injury. That's shifting over to Stanford now. Stanford is going to be responsible for doing that. So I'll get into that next. So these are the guidelines the Brain Trauma Foundation does. We just did the 4th edition of the adult guidelines, the ambulance guidelines on the 3rd edition. We do the combat guidelines for the military. We do surgical guidelines, and we do kids. These are the pediatric guidelines. So if you want to look up severe TBI, best evidence guidelines, the Brain Trauma Foundation does it. This gets translated to Russian, Chinese, Spanish. It goes around the world. And it's a lot of work. Next. And lots of people involved. Here's Odette Harris. She's one of the authors in the guidelines. She's co-director of trauma program here at Stanford, and she's actually trained as a methodologist. We have people from all over the country and world working on. This is just the adult guidelines. We have a whole bunch of people for pediatric and ambulance. Next. So the goal is develop guidelines, put them into trauma centers, collect the data from the trauma centers. That feeds back to improving the guidelines, and you have a closed loop. That's what we do. And that's actually the TBI guidelines, one of the few guidelines in the world where you have this closed loop. We collect data, and then it improves and comes back. Next. Then we have this huge database in New York. We collected this is from patients in 22 trauma centers in New York. We collected the first 10 days of their hospital record and their CT scan. Next. And we published in mainly the Journal of Neurosurgery all the findings we found And this led to better evidence for the guidelines. A lot of it was, so one of the things was people didn't like to do brain pressure monitoring. So people come in coma, the brain swells. And so a lot of people said, I'm not going to put a monitor in, I'll just guess what it is and give something. But it turns out the mortality is higher if you do that. And so measuring is very important. Next. And so we found, here's New York State. Here's when so some of the trauma centers in New York State were following the guidelines, a lot weren't. So we started in 2000, we trained them up. And what happened was the mortality dropped by 50%. We went from here down to here in terms of mortality. And the guidelines compliance went up in effect. This is perfusion pressure management, which is part of the guidelines. So as that went up, the mortality went down. So it's showing you that when you put evidence into practice, you can get real changes. Now, this is a 50% drop in mortality. In the meantime, for the last 20 years, there have been 40 pharmaceutical drug trials in traumatic brain injury. They have all failed to produce any change and costed billions and billions and billions of dollars. And here, we're just putting in best evidence into practice. So there's some thinking that when you go in the lab, and, there's a whole issue of basic research translating into clinical research, which none of it has happened, unfortunately. If you took all the research in traumatic brain injury in rats and so on, you could forget about it, and there's no difference. It would not change our practice with patients. So it's unfortunate. And so really you can get a lot out of just putting basic principles in. And at the end of the day, for severe traumatic brain injury, it's about resuscitation. In the ambulance, give you enough fluids. In the ER, give you enough fluids and oxygen. In the ICU, monitoring brain pressure and making sure the brain's perfused. That's what it's all about. Okay, that's what produces good outcomes. It's not an NMDA antagonist, not a calcium channel blocker. It's not unfortunately, those are all really interesting things, but nothing's come out of it. What this is just showing perfusion. Perfuse the brain, you get better outcomes. Next. So the CDC did analysis of our guidelines and concluded that there's a 50% drop in deaths when you put these guidelines into practice. So, for me, I knew traveling around the world and going to the United States that this is a big problem. There's still, there was a lot of problems with putting in best practice according to evidence. And if you could just do that, you'd get a big change in outcome. Forget about developing some novel chemistry or whatever else. It's about just variance in practice produces real big differences in outcome. Next. So the American College of Surgeons now, they really sort of give the rules for all the trauma centers. They recommend that all neurotrauma care should be followed with the Brain Trauma Foundation guidelines. Next. So yeah, so this was, I was a first-year resident, and I was making Swiss cheese out of the frontal lobe. You see, make a hole in front of the head here, and you put a tube in, and you try to hit the middle of the brain right here, where the spinal fluid is. And we do this for monitoring brain pressure or shunts or whatever. And you learn as a first-year resident how to do this. And so they tell you to point towards the ear, point towards the eye, and go for it. And I never understood that, really. So actually I went back into, so this ended up on the front cover of Journal of Neurosurgery. I'll show you why it's a tripod. It's a tripod with the middle part for the catheter to go through. And we got the front cover of Journal of Neurosurgery. I was a first-year resident at Cornell. But it takes implicit knowledge. It takes 6 years, 7 years to learn. Now a high school student can do it because it's principles. Next slide. So yeah, this is a freehand way. So you just sort of point towards this way and point towards that way, and hopefully you can get it. Next. And the reason the way that it worked was if you look at the ventricle, that's where all the new brain cells come off when you're born, and there's glial guide fibers that could come off radially, and the neurons climb up and form the brain. So actually, what happens is it's a circle, and the middle of it is where the brain cells are being generated. And so all you're doing is you're following the glial guide fiber back into the ventricle by going at right angle. So it's like you're trying to hit the center of a balloon, okay? So if you want to do it, you have to go at right angle to the surface. And that's what was all about. You're just following the neuron back to the ventricular surface where it came from. So if you just make a tripod, you put a catheter through it, you'll hit it every time. So that's what I did. I went down to the machine shop at Cornell. This 2 German guys told me to make a tripod with a little lumen in it. And they made it for me. It's like this big. And I took it to the chairman of neurosurgery and I said, I'd like to use this. He goes, go ahead. We haven't got anything else. And so we did that, and it hit every time, and we got it published. And I started a company with J&J called Neurodynamics. It's still selling this guide. Next. And so this shows you, we don't cut this one brain away, but it shows you in a cutaway what it looks like. Next. Some gory slides are coming up. If you've got anything about seeing any blood or anything like that, turn away. So just show you how we do it. So we measure 10 up and 3 over, so you're in the midline. Next. Then we just shave this area and make a small little incision. It's only like a centimeter down to the bone. Next. We drill with a tripod to make sure that the drill is going at the right angle. Next. Put the catheter in at right angle. Next. And we just tunnel that away from the skin over here. Next. There it is. There's a catheter. That black area here is the spinal fluid right in the middle. And we monitor the pressure. And so people in coma, we monitor the pressure. If it gets too high, we release the spinal fluid, release the pressure, and we also can monitor very accurately what the pressure is. Next. Okay, any questions about coma? Room, halfway.
Yes. So why, I was in a coma for 9 days,
Yeah.
but why does the body decide to shut everything down and put you in a coma?
So good question. So, and the interesting thing is that you're only in a coma for about a week. You can say, it depends. Like a lot of times they'll sedate you, and so when you open your eyes, you're no longer in coma. And so people in persistent vegetative state, they open their eyes. So everyone opens they're either dead or they open their eyes around 2 weeks. Very unusual for somebody, unless they have them in barbituric coma or something like that, induced coma. But if you leave somebody alone and they make it through the first week, which is where most of the deaths are, they will open their eyes in the second week. And so it's that period of time. So then you ask, well, why are people in a coma for a week and they don't open their eyes? And there is obviously damage to their retina. So there's 2 ways to get in coma. One is to brainstem damage. So if I can take a thing and cut the brainstem and go into coma. And the other one is pancortical. So the whole cortex, you put ice on it, we go into a coma. So those are 2 ways to go in coma. So for a traumatic brain injury, it's probably a combination of both, right? You get this big whiplash motion, there's shearing injury, there's disconnections, there's swelling, and that swelling takes a week to resolve. But whatever it is, the eye opening. So it's probably eye opening, it's probably brainstem and some cortical function. And so when the swelling goes down, you open your eyes. So it's about a week. And it's interesting that concussion generally takes 90% of people recover within a week, which is sort of the same thing. So they probably have the same process, but to a different degree. So people in coma have a lot of swelling, a lot of tearing. It takes a week for the swelling to come down, you open your eyes. For concussion, you have a little bit of swelling, you have some problems, but then it resolves in a week. You know, some people don't, take longer, we can discuss that. But that's generally it. Okay, so now we're going to switch over to concussion, which is, I got interested in about 15 years ago because I was very interested in how people pay attention. And it turned out that concussion was a great sort of model for looking at disruption of attention. And I've got some literature in here. So it turns out your brain's about 2.5 seconds in the future. Yes. And actually there's a guy, did anyone go to Berkeley? Anyone go to Berkeley undergraduate? No Berkeley people? Okay. So there's a guy over there called Benjamin Libet, who died a few years ago. He's a neurophysiologist, and he did some very interesting experiments. He had Berkeley students, so he was very interested in like when you decide to do things, right? When is it you decide to do things? So he had a clock in front of the student, and he had little muscle electrodes on the finger, and he basically looked at when you press a button. He says, I want to know when you press the button. So he also had EEG electrodes on the head. And so the student would look at the clock and see the hand going around, and when it got to 3, he thinks he made a decision, okay, at 3, I'm going to press the button. So he tells the experimenter, when it was at 3, I decided to push the button. So they look at the EEG, and they look at the little electrode on his finger. The electrode on his finger actually pushes down about 200 milliseconds after the student decides he wants to move his finger. So that's about right? So you make a decision at 3, when the clock's going like this, it hits 3, and you push it down, and this occurs about 200 milliseconds later. Sounds right. You make a decision to push down 200 milliseconds later. But then they look at the EEG on the brain, and it made a decision almost 2 seconds before that. In other words, the brain was making the decision before the person indicated that they wanted to do it. So this is very disruptive because you think AI is bad. I mean, so suddenly the philosophers got involved and they said, no free will. Your brain is already deciding what you're going to be doing. So, and then they decide. Then Benjamin Libet said, well, actually, you have 200 milliseconds to decide to say no. So you have some free will, but generally, and I'm telling you that story because it talks about the predictive brain state, that your brain is actually a couple of seconds in the future, and it's already planning things because most of the things you're doing are predictable. Most sensory information, the cadence of my voice, so you're expecting me to have some words and something happened, right? So you're always predictive. You're always expecting the next thing and processing it just in time. You're always going like this, okay? And your brain's always in the future doing that. And so I'm going to get to how this applies to concussion in a second. But anyway, so I was very interested in how people pay attention, and it seemed they're paying attention by being ahead and predicting what's about to happen, and then synchronizing whatever motor function or cognitive function with sensory information coming in at just the right time. And just the right time is a key part, right? So you want to process my words as they come in just in time like this, right? And if you're out of sync, you miss it. What did he say, right? Or if you're playing tennis, when you see the ball, it's actually over there. You have to start swinging your racket before the ball gets there. That's predictive, right? And you got to do it just right, because if you swing too early, you miss the ball. Too late, you miss the ball. So the timing is very important. Timing is exquisitely important. And it's really good in the morning after you had a good night's sleep. It's really bad around now. Yep, 2:30, 3 o'clock. It starts getting wavy. We'll talk about it. Does anyone know where most of the brain cells? So there's about 100 billion brain cells. Right? So actually, it's about 87. But let's say 100 billion. 100 billion brain cells. Does anyone know where 80% of the brain cells are? So you take 100 people, 80 of them are in one little location.
Cortex?
Cerebellum?
Huh?
Cerebellum?
Cerebellum. Which cells?
Purkinje cells?
Little teeny weeny little cells. Granule cells. In the cerebellum, yeah. 80 billion granule cells and then 100 billion total. So they're all sitting there. Do you know where they are when you're born? Those 80 billion? They're all sitting outside the cerebellum. They're the only cells in the brain that haven't descended, make connection. You know when they go down and make connections? When you're playing. When kids play. Because play is about trying to find the connection between sensory and motor synchronization, the timing. And that's why the cerebellum is known as a sort of timing organism, right? It's the clock. It times things for you. And if you don't time them right, you get kind of jittery and off balance and all that. So, relates to this in a minute. Okay, next. So, yeah, concussion's a big deal. Everyone's worried about it. There's 17 kids who die every year playing football, and so they always think, well, they had a concussion. The reason he died is because they put him back in. Well, I mean, they put lots of kids back in. The kids that died probably are from a unique kind of injury, so I wouldn't do it. But anyway, this is enough to drive through this, and dementia are the two things really driving a lot of people to get worried about concussion, especially their kids. So if you have a concussion, you're 3 times more likely to get another one, mainly because of attention. Attention is the main problem, cognitive impairment in concussion. Next. And if you look at chronic traumatic encephalopathy, which is the dementia you see in football players, whatever, some of them, it starts out here in the prefrontal cortex, the attention area, okay? And then it gradually progresses to the rest of the brain. Next. So I'm going to test you on this afterwards. Memorize this. This is great for coursework. So this is a project called a Dynamic Model Initiative that we started with Portland State. There's a systems scientist up there, and we told them to go around the country and interview everyone involved with concussion to find out what it is. And so they started here with all the basic injury. The brain gets hit. What happens? The ions, the metabolism. And then we get over here to perception. Here's my predictive brain state. Then it goes over to here to signs and symptoms, feeling lousy, balance problems, visual problems, and so on. But this is packed, concussion packed. How do we unpack it? Next. So we came up with this. This is our general statement for concussion. Change in brain function. The question is, what's the change? What's the brain function? Falling a force to the head. So you just can't happen if you didn't have a force to the head. You may pass out, but you come back and you're awake when you're examined. And we want measures, not symptoms. Okay, we want to get away from symptoms because headache is the most prevalent, yet 90% of the public has headache. So we don't know if it's a headache from a headache or is a headache from a brain injury. Next. So this is something we're working on now, which is we've teamed up with the Pittsburgh group, and instead of defining all of concussion, we're going to focus on parts of concussion that we see clinically. So I see people with vestibular balance problems, with eye tracking problems we'll get into, cognitive fatigue. A lot of them have migraine. It's actually post-traumatic migraine, not just plain old headache. And a lot of them have anxiety, mood problems. Sleep is always a problem. It's a modifier, and then neck whiplash. So we're getting away from saying after force to the head, you have a headache. That's called a mild traumatic brain injury. We're going to start defining these different categories and then moving from there. Next. So this gets into technology that I developed 15 years ago because I was trying to think of a way of measuring sort of sensory motor synchronization, okay, which is what we're talking about the cerebellum, right? So at the end of the day, those 80 billion granule cells are actually the whole sensory and association sensory cortex feeds into the cerebellum, goes through the 80 billion neurons, granule cells, and they predict the future. They're the ones who knows what's going to happen next. So what they do is they hold back your tennis swing because your impulse is to swing early, and the way you control it is by holding it back. And that's what cerebellum does. It's feed-forward inhibitory timing. So it holds it back so it's just right. Okay? And those circuits are projected to the prefrontal cortex. So it turns out that half the cerebellum projects to motor areas, the other half projects to cognitive areas. So it's controlling, so cognition is really a motor function. So like if I'm talking, you want to process the word a little early, with them holds it back till you get the timing right. So let's talk about concussion. We've got to spot it first of all. A lot of times there are people out here and they say, well, it looks kind of funny, it looks like he's wobbling, we'll bring him out. You don't know. So eventually right now we have spotter technology. We have people sitting up in the stadium looking at binoculars or TVs to see if people look kind of weird. Head accelerometer technology is really great if it was accurate. David Camarillo is here working on some of that stuff, and hopefully we'll get some good technology, sideline view. So once we have that, we pull them out, and we look for visual attention, which I'll get into is my favorite, and then vestibular balance. Both of these have to do with orientation. So at the end of the day, the brain's got to orient to time and space. That's the big problem, and there's a delay in processing. So you have to synchronize with the outside world all the time. And yet you have a delay in processing. So when you're playing tennis, by the time you see the ball, it's over there. So you have to swing your racket before it gets there. And you're doing this all unconsciously because you learned the timing. But with somebody with a concussion, that's disrupted. And you see that often in visual attention, vestibular balance. Next. So, Stanford Synapse, we use this device, which I'll talk about. This is the eye tracking device. It's an Oculus Rift. Has anyone tried VR? Let's try VR. Okay. Google 360 or real HTC, Oculus Rift. The problem with VR is it's just a general word. There's lots of different kinds. This is an Oculus Rift DK2 with eye. So most of the VRs, all the VRs don't have eye trackers in it. This has eye. So when you want to change the scene, in VR you have to go like this, right? But we don't do that normally. We just move our eyes and we change scenes. So this one has an eye tracker in it. Actually picks up the eye movements, and it's eye sync. This is the company I'm involved with. We also do SCAT3, which is a concussion sideline test. Next. So this is it's FDA approved, and this goes on here. You see the eyeballs, and I'll show you what the test is next. So this dot goes around the circles, very predictable. Dot goes around, known speed, and so your brain goes, oh, it's a dot around a circle. I'll move my eyes to be right on it. So your granule cells are predicting where it's going to be. And then you measure where you're looking, where the target is, and you measure the variance in this direction and this direction. We're looking at wobble, how well you synchronize. Next. So here's a normal person. Looks like the eye's going around a circle. Here's the target showing all the eye positions. So they're tightly around the target. A low score means low variance, low jitter. That's really good. Here's a concussion subject. Look what happens. Their eyes jump ahead to where the target's going to be. They have a problem with inhibitory control. So it's like they're swinging the racket before the ball gets there. And this is what we see. This is what the way you're in the present moment is by inhibiting the future. That's the best way to look at it. Kind of weird concept, but so your brain's in the future, and the way you end up in real time is by inhibiting it. So when I see these whiskers here, I know it's a concussion. Okay, and so here's somebody's really good. Here's our norms here, and here's where the person is here. This is a really good score, by the way. And it's people who have concussion, they're here, and they come back into this area here over time. So here's somebody with these are usually so we do eye tracking in all the Stanford athletes, baseline for the part of the physical, and we use it on sidelines of football games. And so and I see the athletes all of them. By the way, wrestling is the worst. Does anyone know a wrestler? Just awful. Three quarters of the team have concussions. If the NCAA's reported this too. Wrestling is the #1 cause of concussion. Actually, I should really say it's bicycling is #1 cause of concussion because there's more people biking. But if you look at sports, it's wrestling. So here's the usual Stanford athlete. Gets a concussion. Oh, here's the baseline. Gets a concussion and then recovers like in 2 or 3 days, very quickly. Other people can have very, very slow recoveries over weeks and months. Next. We also took, so this is all funded by DOD, Department of Defense, and so we took 100 soldiers and we sleep deprived them. So here's 6 o'clock in the evening, keep them awake, torture them, don't let them go to sleep. And what do you get? You get this big fuzzball, but you don't get these big forward jumps. So I can tell, most Stanford students look like this. They're all sleep deprived. Okay? I'm not kidding, they're all sleep deprived. If this is over 0.5 variance, it's sleep deprivation. But the concussion subjects are also sleep deprived. So I can see a lot of students are sleep deprived. Next. So this is a paper I wrote with Rich Ivory from Berkeley. He's chairman of psychology at Berkeley. He's a cerebellum expert. He wrote this predictive brain state, timing deficiency, and traumatic brain injury. This is the attention circuit. Cerebellum, so the prefrontal cortex says, I want to play tennis. The parietal lobe tells you where the ball is going to be, and the cerebellum tells you when the ball is going to be there. That's how it works. So this circuit, anytime you're paying attention, this circuit's always active. And we think that the shearing occurs here from traumatic brain injury. And then timing is off. Next. Yes, here's the timing thing. So it takes him 250 milliseconds to actually see the ball, so it's over there. There's a delay in the swing. The ball's going 100 miles an hour. Go figure. You got to synchronize. You got to learn to predict when the ball is going to be there and swing your racket before it gets there. So it's called spatial and temporal prediction. Next. And this is just the cerebellum showing the projections to motor cortex and prefrontal cortex and the involvement in space and time. And the dentate nucleus in the cerebellum has now been found to half of it project to motor cortex, which every medical student knows about, but they didn't know the other half projects to cognition, which is really interesting. Next. So this is all about hiring 20-year-olds. Okay, so if you look at variance, we're looking at variance, jitter. So jitter is a metric of sensory motor synchronization. So here's very young kids, which I have right now, and they're like this. They're running around all over the place. And their reaction times are variable. So if you give them a stimulus and tell them to press a button as soon as possible, they're all over the place. High variance. And then as they become more and more predictive, they get better and better and better. And so until you're about in the 20s, we want to hire all these people here because they have very low variance. They can play music, they can hear music, tap, do all sorts of things, do their job at the same time. They don't have much content, but over here, us guys, we have a lot of content, but we're getting jittery. So it's kind of going like this. And here you can see it, very, very young kids all over the place, the 20-year-olds. As you get older, some of us trying to hold on for dear life. But next. Well, you know what we do is you slow it down. When you talk with us, it's a little bit slower. Because then we can control the variance by controlling the timing. Whereas you get 20-year-olds, so why use eye tracking? Because it's a similar network to the attention network. Most of the injuries in the attention space in the brain has low variability. You can measure the variability of eye movement rather than just sort of reaction times. Eye test, retest scores. It takes 30 seconds to do this test, by the way. So it's 30 seconds. Next. This slide we just put together, look at oculomotor, vestibular, cognitive, cervical, migraine, anxiety, for people with concussion. Next. And this is my current favorite theory, that what's going on is that we're constantly orienting to time and space, and that concussion is an acute disorientation disorder. You get banged, and the first thing that goes out is you become disoriented. And you can measure it with eye tracking and vestibular function. And then as a consequence, because of this, and this altered, so self-agency is basically a validation of sensory motor synchronization. So when you hit the tennis ball, you say, who hit the tennis ball? You. Okay? But you're always doing it. You're hearing things. This thing coming together, what you expect, what happens, is a validation of self. You get a lot of these. After a while, self becomes a little bit wobbly. And that's what happens with people recovering from severe traumatic brain injury. The sense of self is disrupted because you don't get this anymore. Okay? And unfortunately, the kids that are growing up these days have too much validation with simple taps on the screens. It's a little discussion. Okay, so what is it? Here's the triggers, though: migraine, anxiety, and cognitive fatigue. This is the main problem, and this is what happens afterwards. Next. So we finished. We're funded by military to do 10,000 people. We finished that. We did 5,000 soldiers at Fort Hood, and we did 3,000 civilians and athletes, and followed them with concussions. And we just gave this report in, showing that eye tracking correlates with the symptoms after an injury. We're also doing the goggle study on the sidelines at Stanford, USC, Oregon, Utah, Santa Barbara. Also at Clemson and Notre Dame are also using it, and a bunch of schools and clinics, and things like that. I think that's it. Yep. Okay. Thanks. Any questions?
Yeah, so you mentioned that the healing mechanisms for coma and concussion are pretty similar, just like to varying degrees. And I was curious, like, if this technology could potentially be used for more severe forms of TBI, like after the patient's woken up. Like, can you still kind
Yeah,
of
well,
gauge
you know,
recovery?
I
that way?
gave a lecture to neurosurgeons last year about the role of the eye in coma and concussion assessment. And, you know, we don't use enough of this technology in the ICU because what happens is in people that who are like under anesthesia, if you look at, the eyes aren't conjugate, they're like this, right? And then as they come out of anesthesia, the eyes come back to normal conjugacy. And then they start moving together. So you can evaluate everything from coma, and we have pupillometers too that look at the side, the response to the pupil. So there's a lot of things you can do with the eye in people in coma that are prognostic, diagnostic, and interesting. So I think it's underutilized right now. Yeah.
What do you know about or think about like with mouth guards with regards to concussions?
Yeah, I talked about it. Actually, let's go to the next slide. Let's see.
Did I miss it?
Oh, no, I should go before. I don't
yeah,
have.
like, I don't know, is that related to the cervical spine thing, or is that separate as well? I have a friend whose dad is like a dentist and stuff, and he insists that like wearing mouth guard is almost more important than the helmet aspect of it.
Oh, okay, prevention.
Yeah, sure.
Prevention. Preventing head injury. Next one. Okay, so how do you get a concussion? Here it shows the brain whipping around. And why is it? So a lot of people think that, so the person hit their head in the front, right? So the front gets damaged, right? Or if they fall backwards, the back part gets damaged, right? Right, so I fall back, hit the pavement, and have a big blood clot here, because it hits there, right? I've never seen a blood clot from trauma back here. You can see blood clots on the outside of the skull. You have skull fracture, you little epidural. There's no blood clot there. They're all here. No matter where you go, how you hit your head, they're all up here in front. Every time I operate, huh?
Even
Side, right here, just like there. Anterior temporal lobe and prefrontal frontal lobe. That's it. If I see a blood clot back here, I'm thinking amyloid, vascular malformation, not trauma. Doesn't care what. What's this here? Well, forget that part. Because the brain is rotating around a fulcrum. It's the neck producing a concussion. This thing is flopping around this, and this is right over it. It's going to be very little shear forces. But way over here, the problem is it's evolution. We should have developed cone heads. But the brain should have gone up that way, and then we wouldn't have a problem. Okay, well, focal brain injury. But it went out from the neck. Just like having this thing. And that's what happens. This thing over here, this is the frontal lobe and temporal lobe. Back here, look at this, nothing's happening. Here's the occipital cortex. Back here, nothing happening. Okay, next. So, that's just not even a hit to the head. That was a hit to the chest, producing a brain injury. So, it's really the neck is producing the whiplash. And we know that women get more concussions per gender than men do because they have a lot more flexibility. You have to go like this, right? Like that. They have a lot more degrees of flexion than men do. And so they can really flop the brain around. So I like to say women have big brains and narrow, long necks. So where you get it next. So we know the hands device in NASCAR racing, actually brain injuries have gone down dramatically. You lock the head in so the neck doesn't move, and those guys hit the wall at 200 miles an hour and walk away, nothing, no problem. Because they're not getting a whipping, right? The problem is it's an engineering problem. You want the person to move their head, but so next. So David Camarillo is doing a lot of work on this, looking at the neck dynamics of this, and there's an Army lab that's actually making tethers that go here that actually restrain the head from whipping. And that's going to be the ultimate solution. This is going to prevent traumatic brain injury. Well, probably convert traumatic brain injury into a focal injury rather than a shearing injury. Okay, I think that's it, yeah. All right, yeah.
Sorry, follow up on the cervical, so on the neck thing and whiplash. For treatment of that then, what do you think about like chiropractic techniques or like the yoga? I don't know if you can.
Yeah, so we take the athletes through a series of exams. We do the eye tracking, and then we do vestibular, which is this, back and forth the field. You can see how well they focus. And if they clear that, then we look at the neck. If they've got neck problems, we do neck PT, chiropractor, whatever it takes to release the neck muscles and tension. Because the neck can send a lot of bad signals to the brain. And you get dizzy, headachy, and a lot of other problems. You have to isolate where the problem is and then target the treatment. Yeah. Okay, thanks very much, Michael.
All right, let's give Dr. Ghajar a round of applause.